So today is today the first official day of spring? Is that correct? Is that why Google is flowers? Okay. Well, that's nice. It's going to be 30 degrees here in the morning. So that doesn't feel real springy. I hope everybody had a good break. We hope y'all were able to take some time. This is our last meeting before, I don't know. Yeah, right. Probably there will be a good break in August. We know that for sure. Snow and ice in the Northeast. Yeah, it's been awful up there with cancellations of flights. I'll be glad when it warms up for y'all, for sure. But this is our last meeting before the exam, which will be Monday. And this kind of unit that we've been on is less information heavy. And I think that's a good thing with the personality disorders and suicide. This is things to know and be very familiar with and figure out how you might implement this in your practice. We'll just kind of go through it. So the two PowerPoints, we'll start with the suicide PowerPoint. I made an edit to this. I updated this because it was way long overdue. Information is not that different. The take-home point is that while suicide is not one of the highest causes of death in the United States as a whole, it is of the causes of death to people in these age groups listed here, and these are a little different from the PowerPoint. It's based on 2015 CDC data that suicide is the second or third leading cause of death for people aged 10 to 34. And as Dr. Fogger saying it is preventable. There are warning signs that we can look for, and there are interventions to try to reduce it. And that's one of our big roles as Psych NPs is early identification and prevention, education, try to reduce the stigma of mental illness and reduce the things that make people not want to go to care. So it's the second leading cause of death for teenagers, young adults, behind accidental injury, so car accidents and those kinds of things. And even for kids aged 10 to 14, it's the third leading cause of death, only behind accidental injury and cancers. So we don't think of young kids as really being at risk for suicide, but it is still the third leading cause of death of people in that age group. And there are certain risk factors, and we'll talk about asking for those. But then just because it's the third leading cause of death, second leading cause of death, doesn't mean it happens a tremendous amount. It just means this is a really healthy age group who isn't dying from heart disease and diabetes and those kinds of things. Highest rates over 65, that's sort of the kind of standard we always think about, but it is increasing among younger age groups, which is concerning, in particular among veterans under the age of 35. When y'all think of risk factors for suicide, kind of what comes to mind? Kind of those classic risk factors of a pending suicide. What y'all think? Substance, sure. Prior history, yeah, good. Excellent. Demographic kinds of things, because those are really good. Those are absolutely. Any demographic? Sure, it may be less financial stressors, social stressors, poverty, minorities, old white guys. Yes, single old white men who live out in the country and have guns. That is almost the stereotypical picture of what we go with for that. And that remains true. They're just not the only folks who will suicide. As we mentioned, younger rates are increasing. Men will complete more suicides due to the typical means, and women will attempt more. And because the reduced lethality of the means, more attempts, fewer completions. And it's interesting. This has always been a surprise to me that folks who complete a suicide have been seen by some sort of care provider within a recent period prior to that. That's just amazing. So one of the big things about suicide is while they are preventable, they're not 100% preventable. But we want to do the best we can and everything that we can do to try to reduce the risk, to try to intervene. American Psychiatric Association has released, they maintain practice guidelines about specific things to look for. These are things to memorize. These are a lot of things that y'all said. Substance use, trauma, you mentioned, any kind of significant stressor, a loss of a family member, loss of a job, recent diagnosis of a medical illness, some kind of terminal illness. Past behavior indicates likelihood of future behavior. If they had a previous attempt, you would certainly want to know, well, how did you do it? And what were the means? What sort of led up to it? Because you're trying to compare their current behavior pattern with the behavior pattern that resulted in or culminated in a suicide attempt. Were you depressed? Were the stressors at that time similar to the stressors going on now? Kind of are they kind of exhibiting the same things that correlated with the previous attempt? There's theories of suicide and some interesting things that theorists will say as far as like causes for suicide. A theory behind suicide is if certain things are in place, people seem to be much more likely to attempt and complete a suicide. And one thing is pain, the presence of distress, emotional pain, physical pain. So you look at things like trauma, things like depression and illness, a stressor. Another factor is that people lose hope that it's going to get better. Those of you who've precepted at the VA, what's a very common question you hear asked to people who are depressed? It's something I've heard so many times at the VA. Exactly. Yeah, Jean. Do you feel hopeless? You'll have notes documented. Do you feel hopeless or helpless? Do you feel hopeless or helpless? And that's because hopelessness, and it's not going to get any better, and I sure can't do anything about it. You also think about the depressive triad, if you remember seeing that in some of the readings in the depression section, that it's not going to get better. There is something bad, and it's not going to get better. I'm hopeless. That seems more highly correlated to suicide attempts. So those can be helpful questions to ask people. And a third factor that seems to precede this is a loss of connection, a feeling of isolation, that there is no one really here with me. And with Maslow's hierarchy, do y'all remember kind of what are the lowest levels of Maslow's hierarchy? I get these confused sometimes, but what the bottom two are. Yeah, one is safety. Sure, the lowest one, yeah, safety is really good. And then the lowest one, yes, Adam, is kind of those physiological things. I need air, I need food, I need water, I need fire, I need gas, money, lodging, pretty much. And then above that is belonging. That is such a basic human need that it's right there above, shelter, pretty much. So yeah, love, belonging, human connection, that we can't overestimate the importance of that. So when you're asking folks who's in your support system, that's what you're trying to get at, is not only who can you maybe involve to get this person toward recovery, but are they isolated? Do they not recognize any people in their lives who are really going to be helpful there? So just think about, is there distress? If they're there to see you, probably assume that there's some sort of pain. Is there hope? And do they feel isolated in it? Now, none of those are really depression symptoms. So if you're listening for those themes or you ask about them, that's really good. And then, of course, y'all know do they have a plan? Are they thinking about hurting themselves? Have they thought about how? Y'all know all this already. This is not new to you. Have they thought about it as much to where they've thought about how they would do it? Do they have what they need to do it? And is their plan to take, I have a half a bottle of melatonin and I think I'm going to take it. Is that their plan? Or is their plan 2 bottles of Aleve or a gun, or I'm going to turn my car on in my garage, those kinds of things. So you want to be sure to do a thorough assessment to see how far down the line they've gotten with that. And one side note is assessing for suicide is something that can make people uncomfortable. So if anybody has ever found themselves, I really don't want to ask this question, or I'm not real comfortable, I don't want to upset the patient, I don't want to bring up a difficult subject or anything like that, I don't want to offend them, that's really normal. And the more you do it, the more normal the asking and more natural the asking will become. And considering that these folks have seen a provider within a month of completing a suicide, really important that we do. So those physical illnesses, significant diagnosis, a life-altering diagnosis. So be sure that you would have those kinds of things memorized, that you would recognize those risk factors. If you were presented a case, you would say, this is 2 risk factors, 3 risk factors. This is a question I would ask. This person is at higher risk than that person. You want to be real familiar with those. But at the same time, there are protective factors that you're listening for too, that these people with these resources here tend to be at lower risk for suicide, and a lot of them are social support, a good relationship with a provider, children for whom they are responsible, a connection to a higher power. I wouldn't do that to my kids. I wouldn't do that to my spouse. I would never. So belonging is so protective. And when you work, for those of you who work with people with trauma-related disorders, what is often something that's lacking in their landscape? From this list. Any thoughts? Some of the symptomology of PTSD and how it might impact quite a few things on this list. Well, foreshortened future too, for sure. When you think about folks with PTSD, in particular the more severe, there is a strong dislike of intimate socialization. There's not trusting, warm, fuzzy feelings toward people. People are not necessarily comforting to them. They feel detached from people. They don't see generally other people as something that's going to promote their survival. Other folks largely are going to be seen as a stressor, an unpredictable thing that they stay away from. So we certainly want to think about the patients that you're working with of, on a scale of 1 to 10, how socially connected is this person? This one's an 8. Oh gosh, this one's a 1. They may have one friend, and that's kind of the only, a guy they served with who they'll talk to on the phone maybe once a month, and that's kind of their main social support connection. Anytime you can get guys to to kind of brainstorm who do you trust, who can you be in more, who can you be more connected to, who would you reach out to if you had a problem. If you can get them to go to some, like a support group that might be fitting them, or even are you willing to see an individual counselor just to have another person? And Adam, you're mentioning PTSD domain. That would be in the alteration to mood and cognition, just kind of not generally being numb. I think Amber mentioned the numb kind of feeling, just not being connected to other people, feeling different from other people. Yeah, that's a good question. Because what's affected is their how social interactions are processed for them. They're not supportive there. And you can work with a lot of folks with trauma-related disorders who are still they're tremendously connected to a spouse or to a child. They would do anything for that person. That person hung the moon for them. So it's not to say that all folks with trauma-related disorders are robots who want no one in their lives. We just want to attend to how many support people they have and try to foster connection because of how protective that is. And be okay if they don't want to, because that's also very possible. And what is the best option for those who say they don't have any connections or support? Ow. Well, one thing that I would say to that is they are willing to come to you and to your clinic. So they see people or providers wherever you are as potentially being helpful and trustworthy to them. So that's a place to start. I approach that with just lots of questions, open-ended. Who do you, like I had mentioned, well, if you had a flat tire, if you needed a ride somewhere, who would you call? Who would you ask? And if they will nobody, say, okay, well, when's the last time things were different? When's the last time you did have somebody that you could call? Just really, really open. Anybody from the service that you could trust. Last time you went to have you ever gone to church? You can go backwards and say, well, when's the last time? And just see what they say. Family, friends, former coworkers, former bosses. And a lot of times people will say, well, yeah, I guess there was that one person. Because there was a point in time when these people did not have PTSD. This is a point in time syndrome. So you can even ask, well, before. Because the more distress people get in, the less broad their focus can become and the less well they can think historically. Because trauma activates the fight or flight, which is, I got to fix right now, and I don't care about the future, and I don't attend to the past. Those, your forecasting ability, that's the front part of your brain. Your history, and well, what worked last time? And well, it wasn't always like this. That's all hippocampus. That's not working. Blood's being rerouted away from those areas to fix the immediate. So we have to help, it's always been horrible and it's never going to get better, and it's always been this bad. Always that kind of speech is the speech of someone who's in distress, and needs you to be like a scaffold and help them get out of that line of thinking to help them come up with solutions. This is just coping skills you're modeling for them. But that's a really good question. So the intervention, we talked about risk factors and those kinds of things, protective factors. So what do? You assess severity, and safety is paramount to confidentiality. If you have concerns, you have to involve other providers, you involve family, you involve spouses, you do all those things. You get, whatever the lethal means are, you try to get them removed and get a reliable other person to confirm. There have been many times when I was seeing patients at the VA that I would have a discussion with the patient of, I think for the next little while, until we let the medicines work better, until things kind of level out, I think it's important that you don't have any guns in your home, because it's just, people don't necessarily think when they're in a really bad place. So let's just eliminate that and let's get that out of there. And I'd call a brother or an uncle or a friend, and they would go get the gun and they would remove it from the home. And then I would speak to that person and make sure, and they'd say, yes, I have it, and I'll keep it until you tell me otherwise. That's perfectly okay. Of course, the patient has to agree to that. So what do you do when they don't? When they don't agree that? If you're really concerned about the person's safety, they meet XYZ criteria, you can recommend hospitalization. And there's been a change. I guess if someone comes into an ER, then they're there, and the attendant can put in a do not AMA order, and then security will physically, retain the person. But if someone's in your outpatient office and you really want them to go in the hospital and you can't just grab them and, across from you. So, in those instances, that's when you would call the police and family members to let other people know you're really concerned. And you'd call the police to go do a well check for that person. But I had an issue recently. I don't know how it is in other states. It used to be that if you had a concern that someone was suicidal, that the police could go and pick the person up. But I don't think it's like that in Alabama anymore. All the other providers in Alabama who were here let me know. Because I knew of some folks recently who the woman really needed to go inpatient because she was psychotic, but the police wouldn't take her because she hadn't done anything. She hadn't been violent towards herself. Okay, so in Texas, there's a peace officer's warrant that they can involuntarily accompany the person, maybe to an emergency room. Gosh, yeah, that was disturbing. That was disturbing because the police called an ambulance last time we had that. Okay. Then, maybe once the police are involved, they can. But there's an issue now in Alabama that unless someone has actually attempted, there's a limit to what we can do against people's will, assuming they have intact reality testing. Well, actually, I say that this woman did not have intact reality testing, and they still wouldn't take her. So just be sure, and this is you want to know about patient rights, you want to know about privacy, you want to know about duty to warn and duty to report, and that's really all that's kind of the extent of what we can do, is inform family and document it, inform the emergency workers. And that's kind of it. So Maryland has a petition. Sure. And that would be an option too, that you could petition someone that they're immediate harm to themselves and go through your county probate court and those kinds of questions, that's great that you know how each of your states work, what your options are. Those kinds of that detail won't be on boards because that's a national exam. But things that might be on boards are confidentiality versus duty to protect, because that extends, across everything. And that you document. And you would want to discuss this with your collaborating physician, because both of you are liable for any outcome that happens to a patient. So you would certainly want to involve if you're in a state that has that. Alabama is a state that has that. Other options kind of in between are going to be, the patient goes home with a family person and you say, look, I want you to call the clinic in the morning to check in. You can have something in between, I'll see you in 3 months, versus you need to go to a hospital. You can have more frequent contact. Deborah's saying it got really crazy, so they called the police, and the police got there to arrest the woman for being suicidal, and she got upset and tried to leave. Yeah, that's the problem, is that it's against the law to have mental illness because the police come. But it's the best that we can do right now. Oops, we didn't need that. There we go. Kind of more specific, we try to include information specific to our veteran population, in particular with our program, and just some things to keep in mind about vets is that if you're working somewhere outside of the VA, younger veterans, because this is an age group that's increasing risk for suicide, is the younger veterans. And a lot of vets don't use the VA, and in particular the younger folks who aren't plugged into the VA tend to have attempt and complete suicide more than folks who are plugged into the VA. So hey, recommend that these folks see somebody at the VA, go check out the services there, because there is something just inherently protective of that. And also veterans, so younger veterans who aren't being seen at the VA, who live in rural areas, who are having significant sleep disturbance. That's a big, big risk factor, so we always assess sleep. And then if they have vets with a comorbid mental health concern, substance use, relationship problems, these need to be huge red flags. So for those of you who aren't in a VA, you always want to ask, have you ever served? Because just know that those are younger vets, relationship problems, drinking a little bit, not plugged into any kind of VA treatments, living out in the country, access to guns. I don't remember if we posted this article. I'm going to have to see. But this is a different approach to a no harm contract. It's almost like a problem-solving, coping plan to work with folks who are endorsing suicidal ideation, and maybe even they've thought about how they might do it. And you start, so A, B, C. These are all things that we just talked about. Your risk factors, what are there? I guess D as well. Social resources, internal coping resources. Is the person, are they a fairly intelligent person? Are they articulate? Do they have a history of being really impulsive? Do they have are they comorbid for perhaps a head injury that may have them a little more impulsive, a little more prone to emotional kind of lability to anger outbursts, those kinds of things. Family support. So this is pretty standard. It's more than just I agree to not hurt myself, and this is I will come back and see this appointment with this person. You're getting them to discuss protective factors in the process, like the family support, like coping resources. and it ends with removal of means. And sometimes removal of means going in a hospital. If that's the only way to remove the person's, limit the person's access to means, then that would be the intervention. So it's really designed to be more constructive than just a do no harm, than just a no harm contract. It's okay, well, what am I going to do and what is in place so that I won't, so that recovery and doing better, getting better, that's what you're focusing on, as opposed to don't commit suicide. The alternative is, okay, what factors, what resources do we have in place and will we put in place so that the suicide becomes, well, less of an issue, less of a option for them. You can do this outpatient. You get them to be consciously, presently aware of alternatives. Not unlike motivational interviewing, you get them to consider the positives of the alternative, as opposed to, oh, there's only positives to this one choice. There is no other choice. The patient's involved. You're kind of modeling them through problem solving, things that they can then maybe do in your absence, which is a big part of behavioral therapy, is people practice things that then they can do on their own. Yeah, these are just additional things to look at with the safety plan from the previous slide. Just more qualitative components to it. It's collaborative. You're encouraging the patient. You're assessing real risk, but it's not just don't do this. It's, okay, what's your plan for getting to where you feel like this isn't even something you need to do? And you get the family involved. You have numbers. You educate family. If this happens, hey, let's get the means out of there. Signs of worsening depression. If the patient increases substance use, that's a huge concern. And then, okay, this is the process for accessing increasing level of care. You can call here. You can call 911. You can get the patient to go to the nearest ER. Just have these conversations, involve support people, and document it for sure. Discuss it with your collaborating physician as well. This may or may not be tremendously relevant to y'all's practice, but this is a safety planning more specific for folks in our veteran population, which is really similar to the approach we just mentioned there. I don't think this is going to be on the exam. This is just more for your knowledge. Things you can tell patients about, especially if they're vets. The VA, the crisis hotline and those kinds of things. And those are just some additional resources, which will be different everywhere for y'all. Best thing is to just know. And Dr. Falker's listed up. That might be something good to post, since that's a web link. Might be something good to post in the discussion board in 622, so people may be able to just click on it. So main takeaways from that: risk factors, protective factors, how confidentiality and duty to protect, which one supersedes the other, how to assess for things, how to ask those questions. Going to be the main thing. So similar but different. This is going to be probably more pediatric focused here, is non-suicidal self-injury. I would think that those of you who've worked with a younger population have certainly encountered people who engage in this. or folks with borderline personality disorder, which is really why we include this in the personality units, because of the overlap between suicide, non-suicidal self-injury. What ages typically engage in non-suicidal self-injury? Well, this is primarily a kind of middle adolescent thing. First episode, so kids who do this, and as you can see, some samples will say, a lot of times these surveys will be done in kids' schools in Denmark, in the northeastern United States, in Central America, and it's really pretty standard that when you ask, so not a clinical population, I should say, that anywhere from 1 out of 4 to 1 out of 2 kids have said, yeah, that at some point I've deliberately hurt myself to affect my mood in some way. When you see kids who are inpatient or have been previously hospitalized, it's almost all of them. So from a non-clinical population, that's still pretty high, 1 out of 2, 1 out of 4, to almost all of them, kids who've been symptomatic enough, distressed enough, dysregulated enough to warrant hospitalization. On average, so sort of the mode of first episode is going to be 13, 14, something like that. So not 8. Usually the first time kids have done this is going to be 13, 14. There are still kids who will engage in non-suicidal self-injury younger, and kids who will start later, but typically it's here. I mean, a particularly difficult time in everyone's life. Their 8th, 9th, 10th grade year of high school. Girls tend to engage in this more than boys. There's usually one preferred means, but they've tried more than one. So if you would ask kids, have you ever cut yourself to try to feel better? If you're real upset, have you ever burned your skin? Have you ever kind of poked your skin with nails? Those of you who've worked with kids, kind of what are their typical means that y'all have encountered? Yeah, lots of cutting, Adam says. Cutting. Kind of scratching with fingernails, cutting. Primarily razors. Yeah, there is something about a cutting injury to skin that, and there are different pain pathways and different, we have different nerves to register different kinds of pain, sharp pain, dull pain, cutting pain, burning pain. But there is something about cutting that seems to activate a corrective mechanism in the brain other than punching, biting, slapping. Some kids will punch their stomachs, punch, all sorts of things. Tracy Hartley's talking about pulling out hair. Yeah, that can be. And then you get into compulsive behaviors that are maybe even similar but not exactly the same. Head banging. Yeah, in particular, kids with developmental disorders, severe forms of developmental disorders, you'll see a lot of self-injury because of its regulating ability. So again, most kids have tried more than one, but then have a go-to. Comorbidities, other means of trying to regulate affect and cognition, like drugs and tobacco and eating disorder behavior with a trauma history. And when you ask parents and when you ask providers, without exception, they underestimate the frequency of non-suicidal self-injury. So it's happening much more than anybody would assume. And you can hide it a lot of times. This is typically a very private behavior. Just some other little facts. that adolescents, these 13, 14, 15-year-olds who self-injure, not for the purpose of killing themselves, that is not the purpose. They'll say, no, that I'm not trying to kill myself. They're more likely to self-medicate than adolescents who don't self-injure. And they more than adolescents who do self-injure versus adolescents who don't tend to have ruptured parental relationships. This gets into the category of not only, of course, physical or emotional abuse, but more so neglect, not being responsive. So parents who don't communicate to them, parents who don't attend to them, parents who maybe have a drinking problem, parents who are absent because they have a mood disorder, parents who are absent for any number of reasons, but kids who describe their parents as emotionally unavailable, unresponsive. Neglect can do more damage than actual physical abuse. And it's really highly correlated with self-injury and development eventually of certain personality disorders. So when you're working with kids, it's good to see the interaction with the parent. See which parent comes to the appointments. What's the parent's attitude and demeanor with the child? Are they dismissive? Are they critical? That's why it's good to spend at least some time in every visit with both. And like we said, the goal is not to end one's life. That's not the point. But substance use, trauma history, mood disorder, limited social support, those are also risk factors for suicide. So you would assess for suicide as well, but it doesn't mean that is the purpose. It can mean different things for everybody, and often it's those that we have listed here. They want to feel something. They want to feel nothing. They're dissociating. Because the adolescent brain, it's not finished wiring yet. It's not finished pruning. It's not finished wrapping enough myelin around all of the nerve cells so they're connecting to each other parts well enough. So you have kids without any kind of history of surviving hard things. They're sort of stuck in the right now. This feels bad, and what will make me feel better? And causing physical harm to yourself will allow for a resetting out of this disorganized, can't solve a problem, or dissociated state, and then just go back to a clean slate. And fMRIs will actually show that after cutting, women with borderline PD, that their heart rate variability improves, and connectivity between problem-solving structures in their brain, like your frontal cortex, that actually becomes more active than other areas that don't help you solve problems. So there's physiological protective mechanisms that help people feel more in control of themselves, more in the present, more focused. And yeah, the attention seeking, it's like with ODD, if it is next to impossible to get kids can't get their needs met on their own, so they rely on caregivers, adult caregivers. And if it's really hard to elicit attention and therefore resources from your caregiver, then it gets to where people will just sort of do whatever. They'll do whatever it takes, and very often it's the extremes of behavior that is required to get the attention of anybody. So attention seeking, it can definitely get attention. And a lot of the treatment has to become educating the people in the environment to not to increase the amount of care and connection on the front end, and not to provide, oh gosh, I can't believe it. Yeah, I'm only going to care about you when you've hurt yourself. Well, then I guess I'll hurt myself more. That is reinforcing. So some of the things that can be helpful is there's emotion focused therapy, which is manualized, gets the parents and the child in treatment together. It essentially increases healthy attention and communication, kind of like social skills for the parents and the kids again, and the non-suicidal self-injury behavior decreases, and kids' scores on mood scales improve greatly just by involving the caregivers back. And it's really about reducing the frequency of distress that this behavior is trying to fix. So y'all were mentioning that there are websites. Yeah, there are some websites that kind of encourage. Oh, manualized. Anything that is put into a manual. So any kind of cognitive therapy, because it can be very structured, and you do this on week 1 and this on week 2 and this on week 3. It just means some kind of treatment program that can be put in a manual and distributed to people, and kind of to standardize the treatment to where you're not flying by the seat of your pants every time. It makes the interventions more consistent and therefore more reliable. Does that make sense? As opposed to person-centered therapy, where you just kind of go in and you go with the flow. And there are cognitive therapy. You can do cognitive therapy that's not manualized. You just use the things. But like coping CAT we talked about, that's in a manual. DBT is in a manual. There's the seeking safety, that's a manual. So, you're mentioning adolescents, which is the folks who typically engage in this. Well, I mean, because sure, they may not have any other way to cope, and cutting will get everybody focused, and it works every time. That's why people do it. Gets you out of distress, gets you back focused. You don't feel the bad stuff. You don't feel out of control. You actually feel present again. Adolescents don't have a lot of other options, and they're very internet savvy. Gosh, with phones now, man, you can be on, Lordy. There are websites out there that are in, chat rooms and blogs and all these sorts of things that in some cases are kids who are encouraging each other to injure and encouraging each other to how to hide it. And hey, I do this and I feel better. And of course, there's kids this age are desperate to fit in and be similar to each other, so they may try these things. It may be recommended, like, oh, so-and-so's doing this, so I guess I'll do this too. But not all online resources are bad. There are websites. Ooh, I don't think I wrote it down here, but there's websites about recovery from self-injury and tips to kids, other ways to cope, tips to parents, warning signs, healthy alternatives, those kinds of things. So not everything online is bad, but when you know about the desire for 13-year-olds to fit in inseparably, parents have to know what what their kids are looking at, because it might be supportive and it might be not. So, depression, eating disorder behavior, ruptured family relationships, substance use, other things like that, that's going to cue you into this child may be at higher risk to self-injure. So we want to assess for it for sure. And it is okay to ask specifically, do you cut yourself? Have you ever burned yourself? Kind of stick pins under your skin? Do you punch yourself? Do you slap yourself? Just because kids tend to acknowledge when you've addressed their preferred form of self-injury. That if you say, oh, do you self-injure? Just kind of vague like that, they may say no. But if you say, well, do you ever burn your skin? In places where people can't see, they're more likely to acknowledge if you're specific about the means. And this isn't a question you want to ask them the first time you see them, because the better the relationship they have with you, the more likely they will to be forthcoming, like we all would be, I'm sure. DBT, dialectical behavior therapy, a manualized therapy, has a huge focus on reducing self-injury, but it's been adjusted to be adolescent, for an adolescent population. And even basic coping skills like relaxation, which is also a huge part of DBT, is offering people lots of options to practice for emotion regulation. And the internet, like we mentioned, may not be a good thing, but you can direct kids and parents to, gosh, I wish I could remember that website. I'll find it and I can post it in the discussion board. Really neat resource. Because again, this is not at all uncommon. Upwards of half of kids have tried this at some point. Maybe it didn't become something that they do regularly. Not everybody does this. The behavior is serving a purpose. So if kids don't have a purpose for it to serve, they're probably not going to do it. So medications to help. There's no medicine to prevent non-suicidal self-injury, except sort of in the context of irritability associated with autism for kids with more severe forms of autism who, when they're dysregulated, will self-injure. So antipsychotics, sure. Try to interfere with the impulsive, repetitive nature of self-injury. It's done because it works, so it's done because it results in relief. The dopamine has been involved. Your impulsive behavior, compulsive behavior, that network has been involved, and that's when we're talking about. That's when we're talking about the striatum. That's when we're talking about the basal ganglia, things like the movement disorders that come up when we treat people with antipsychotics. Dopamine says go, don't go. Go, don't go. And once behaviors become compulsive, you need to interrupt that pharmacologically. When we look at, kind of up at the top, when we look at, because depression is a risk factor for this, well, if you address the depression, then you improve the risk. Okay, so SSRIs, SNRIs, remember, these are most often 12, 13, 14, 15, 16-year-olds, so think FDA indications for that age group of SSRIs. Your Prozac, your Lexapro, those kinds of things. Therapy is better. You got to install some coping skills. You got to install communication, improve communication with parents. You got to prevent triggers. There's no medicine for those things. Your mood stabilizers may help. They're not FDA indicated, but they may help. Impulsivity. They may help aggressive behavior. Naltrexone has some usefulness in reducing the satisfaction, sort of the dopamine and opioid response to impulsive behavior, to satisfying behavior. Just try to reduce the urge and the satisfaction of behaviors that become associated with a compulsion. Naltrexone is used to help reduce cravings for people with alcohol use disorders. It just makes things, just don't really feel the urge to do it. I don't feel the urge to do it. And that's a compulsive thing. It's not so much that people want to do it, it's that they can't not do it. So if you can prevent that, then maybe you'll reduce the frequency of the behavior. But first, it's got to be behavioral interventions, address comorbidities if depression's an issue. And again, there's the black box warning for increased suicidal ideation, which these folks don't necessarily have. They may not have it at all. And that's just not, it's a risk of starting serotonergic medications, but it's just not consistently exhibited. So hopefully, kind of the take-home message is the frequency with which kids have tried it, the purpose of it. It's very different from a desire to kill themselves. It's about emotion regulation for people with few skills and a lot of kind of challenges. So you address it with behavioral therapy, treat comorbidities. Internet might be helpful. Internet might not be helpful. There's some medicines kind of as third line. But what you find is when you install other coping skills and you improve the quality of interactions with primary caregivers, then often the function of this behavior goes away. Or the folks may, if it does maintain, they may end up meeting criteria a good bit looking like borderline personality disorder. So this next exam, which is going to be in a week, none of this I'm sure is news to anybody, but from the trauma-related section, of course, you want to know the symptoms of PTSD, the risk factors for PTSD, pre-existing trauma, pre-existing mental illness, few resources, those kinds of things. And just the basic physiology, the changes that happen from trauma. Sympathetic tones, it's generally going to go up. The hippocampus is so sensitive to the inflammation in the corticoids that are floating around post-trauma that, it atrophies, it shrinks down. The HPA axis, it can't turn itself off anymore. It was so maxed out, so fried that it can't even turn itself off anymore. Kind of revisit traumatic brain injury. How does cognition change? How does emotion regulation change? What are medicines for PTSD? What kind of different approach might you take if they have a traumatic brain injury from that second trauma lecture that we did? The majority of the test will be on that top part. And then personality disorders will give you a scenario. You want to be able to tell the difference. Maybe there's a medicine that might help. Maybe there's not. And then suicide risk factors, assessment, prevention. And it's real knowledge-based stuff, really, with the non-suicidal self-injury. But it's important to know. So please, if you haven't gotten in just let us know how you want to take the exam. Please get those submitted to the Proctor Form Dropbox. That exam's Monday. And the only other announcement I had is for anybody who is interested in working with kids and adolescents. We have developed and will be implementing in the fall a 1-year post-master's, essentially a residency program where it's an additional year of training and experience and education specific to inpatient and outpatient mental health care for kids and adolescents. We're doing that in conjunction with a children's hospital here in Birmingham. So for anybody who's like, I really think I want to work with kids, or I don't think I got enough experience with kids just because of where my program was. It would require you to move to Birmingham, but you would be employed as a nurse practitioner at the hospital, getting child and adolescent specific training and additional instruction. Really cool experiences. So just kind of think about that. If that's something that would be of interest to anybody. There's not many of these in the country, and we're going to be starting it in October. But that was the only other announcement I had. So any questions from anybody, or questions, comments? Appreciate y'all being here and sharing your experiences working with the different things we talked about tonight. Well, all right, guys and gals, we will stop the recording. And any questions, please let us know.